I'd like to do during this session is to really break my comments down into several parts. I want to begin by talking a little bit about disaster ethics in general. That is, what are the ethical lenses through which we can see and navigate through a disaster situation. I want to define some very broad categories of ethical questions that come up in a situation like the COVID-19 pandemic. I'll then move on to ask very specific questions. I have worked with a number of different healthcare providers on a number of different ethics consults and policy efforts to answer many of these questions. My goal today really just is to get all the questions out for you. And during the question and answer period later, we can zero in on any questions that are of specific concern. I also intend to provide you with several analogies that can help us approach these ethical questions and access some moral intuitions that we already hold, ending by discussing in general the concept of altered standards of care. So that's where we're going to head today. And I want to begin really just by trying to develop an ethical framework or put these questions into some sort of ethical context. In order to do that, I want to introduce you to a technical philosophical term, and that is the concept of a moral dilemma. That may not sound like a particularly technical term for you. People talk about moral dilemmas all the time, but for philosophers, the idea of a moral dilemma does have a very specific meaning. A moral dilemma is defined as a situation in which the existence of contradictory obligations results in the inability to avoid doing wrong. I want to make this clear that a moral dilemma is not just an ethically difficult situation. It's not just a moral bind where we feel some tension, we're not sure what to do. A moral dilemma specifically means that there are contradictory obligations such that if you satisfy one of those obligations, you will, by definition, fail to satisfy the other. In other words, suppose you have a moral obligation to do A and a moral obligation to do B, and if those two obligations are contradictory, it would result in the situation where satisfaction of A necessarily means that you fail to do B, and vice versa. Satisfaction of B means that you automatically fail to do A, which means you cannot help but do something wrong. No matter what you do, you will do something wrong. Now, I want to point out that many philosophers, and I think I include myself in this group, don't really believe that moral dilemmas exist. How can I say that moral dilemmas don't exist? The reason is that when multiple moral obligations come into conflict with one another, it is generally the case that we can prioritize those different obligations and demonstrate that one takes precedent over another. I'll give you an example. If I go out hiking and I get lost in the woods, and I am terribly lost, I cannot find my way out of trouble, and I'm starving. It's been several days since I have eaten. I've had a very small amount of water for the last few days, and I am really getting to the end of my rope. I just don't have much energy left, and it really appears that I'm about to die. But at that moment, as I'm trudging through the woods, hoping for some sort of salvation, I accidentally come upon a hunting cabin. Now, it's sealed up tight for the season. Nobody's there. But when I peer through the window, I can see on the back wall of the hunting cabin a shelf full of canned foods. And happy for me, right on the counter is a can opener. All I have to do is break the window, break into the cabin, and take that food, and I can save my life. Now, some might argue this is a moral dilemma because if I save my own life, so let's start with the idea that I have a right to life. So if I satisfy my obligation to save my own life, I must do it at the cost of breaching another moral obligation, that is the prohibition against stealing. If, on the other hand, I honor my obligation not to steal, then I will die. So thereby, I will neglect my obligation to save my own life. That sounds like a moral dilemma, but in my mind, it isn't really a dilemma because the right to life is more powerful. It takes precedence over the right to property. Now, I may surely develop secondary ethical obligations when I break that window. I may have an obligation to make restitution to the cabin's owner to replace the food that I take. What I would argue in that case is that I am actually morally obligated to steal. Stealing becomes the right thing to do. Therefore, there is no moral dilemma. Now, why do I spend time on this at the beginning of a talk about pandemics? I want to use this concept of moral dilemma to describe what I mean by a disaster. Remember, I'm not an epidemiologist. I'm not a lawyer. I'm coming at this strictly from an ethical point of view. And I would argue that a disaster is not just a really bad situation. A disaster isn't even just a time when lots of people die. Unfortunately, people die for lots of reasons all the time. It certainly is sad, but that does not necessarily make it a disaster. I would argue that from an ethical perspective, a disaster is defined as a situation that involves a moral dilemma, or at least something that feels as close as we can get to a moral dilemma. In other words, we are going to be so pressed to make decisions that feel so uncomfortable for us and so unusual for us that when it's all over, there will be residual pain. The decisions themselves will be difficult without doubt, but we will be so concerned that we did something wrong that even in the aftermath of the experience, we will experience what some have termed moral injury. We will have almost a form of ethical PTSD where we wonder if we're good people because we've had to make such choices that seem, under normal circumstances, to really be unfathomable. That really is what we're talking about when we discuss a disaster, at least in ethical terms. We're involved in situations where we will have to make extraordinarily difficult choices, and whether you believe that these are true moral dilemmas or just extraordinarily serious moral binds, those difficult decisions put us in a position where we're not even sure we did the right thing. And we second guess ourselves. We feel badly about ourselves. We feel badly about our decisions. I think that's the kind of ethical pressure that we are going to feel as the COVID-19 pandemic really hits us with full force. We're going to be forced into these sorts of very uncomfortable ethical situations. Now, having talked about that, we need to think now, what sorts of ethical decisions are we going to have to make? Why is it that we're going to feel so conflicted about the choices that will be before us? I would break down the types of ethical issues that we are likely to have to deal with into 5 broad categories. These are general categories. We're going to get to specific questions, each of which would fall under one of these categories. We'll do that in a moment. But first, just the broad categories of ethical issues. Number 1, allocation issues. This is what everybody thinks about first when they think about disaster ethics, when they think about pandemics, when they think about the coronavirus. We're not going to have enough ventilators for everybody who needs one. We're going to have to say no to somebody. In its extreme version, we may even have to withdraw support from one person in order to provide that support to somebody else. This first category that I call allocation really is pretty patient-centered. How are we going to distribute resources? Things like ventilators, dialysis machines, time, beds, any of the resources that are likely to become scarce. We're going to have to triage the victims of this disease and decide who we are going to serve first, whom we are going to serve second, and potentially whom we will not serve at all. Second general category of concern, liberty type 1. Now, I'm going to split these two liberty questions into 2 categories. Liberty type 1, like the allocation decisions, really concentrates on recipients of care, people who could be sick. They're questions about personal freedom. So these questions would include issues like, when does it become ethically permissible to demand that people remain in quarantine? To demand that people who are positive for the disease be entirely isolated? When can the government order that businesses be closed, that people have to stay at home? All of these actions restrict an individual's liberty, and surely they present ethical questions. That should be held in distinction from what I would call liberty type 2 questions. This is the third category of ethical issue, and they are liberty issues, they're freedom issues, but instead of being based on the recipient side of the equation, This category really looks at the provider's side of the equation. So these are liberty questions that attach mostly to healthcare providers, although I will point out that they could also apply to truck drivers who need to get supplies to grocery stores and grocery store workers who need to be there to deliver the food to people. Do I have to come to work? Do I have to stay on post in a dangerous situation? What about practicing outside of my area of comfort or expertise? I believe that when the pandemic hits our hospital with full force, we're going to have a lot of healthcare providers who get sick themselves and can't work. We're going to start running short of people. At that time, does it become ethical to ask providers to do things outside of their area of expertise? I have some friends who work in healthcare who have told me, you know, I work in private practice. I haven't been in the hospital in years, but I've got some skills, and if they need me, I volunteer, I will go. I've had other acquaintances of mine who are healthcare providers say, there's no way I'm going to go. That's dangerous. They can't force me. It's not my responsibility. What are the ethical obligations? There's an old saying in med school that you see one, do one, and teach one. At what point are we going to take a social worker who's never been trained to give an injection and say, here's some vaccine. Watch me give one injection, then let me watch you give an injection, and then go find 3 people and teach them how to do it. This is going to require a change in many standards of care as to who's allowed to do what or who's expected to do what. And we'll talk about that later. But it's an interesting ethical question as to whether or not you can be pressed into service in dangerous ways and in ways with which you are not comfortable. Category 4 of these general issues is what I call fairness. This is almost the provider analog to category number 1, allocation, where allocation decisions really talked about how we triage victims. That is, who's going to get the resource that we have to distribute. The fairness issues under category 4 talk about how we would triage staff. Which staff members should do what jobs? How will we distribute risk amongst providers? There's a choice, for instance, as to whether or not we should concentrate risk in a small number of providers, potentially in order to keep some other providers healthy so that they can do things that have nothing to do with COVID and keep those other services running, or potentially to hold them in reserve. So if the first string of responders gets too sick to work, then we have a second string that we can put in place. Is it appropriate to concentrate the risk on a small number of staff members up front? Or should everybody just take their turn and rotate that risk around? This could also, this category of issues could also begin to bleed into questions about how we distribute things like personal protective equipment, or even vaccines. When the vaccines become available, should they go first to providers who are on the front line or first to potential patients? The final general category of ethical issues here is public coordination. Now, I want you to know that I actually wrote this slide back in 2007. Anyone who tells you we couldn't have seen this coming, there was no way to predict it, everyone would have been caught off guard, was just not paying attention. We've talked about pandemics for years, and in my own business, I was working on pandemic preparedness policies all the way back in 2007. We've known about shortages with regard to things like Katrina. We knew about H1N1, and certainly we had historical analogies in 1918, not to mention the much more recent experiences with things like SARS and MERS. But when I wrote this slide back in 2007, I put public coordination as a number 5, and I almost decided to lower it down on the slide to make it sort of a minor issue towards the bottom, because although there are ethical questions about public coordination, this is by and large a very pragmatic, very sort of mechanical issue. And I thought, gee, maybe it's not really a core ethical issue. Based on the experiences we are having now, I am moving public coordination back up on the list right with the others, potentially even at higher priority. I do not believe that we have had sufficient proper public coordination on these issues. I think we've gotten mixed messages from various sources. I think we're not sure who's in charge of deciding what policies will go into effect. At every level, it's simply unclear. In my own city, for instance, I am sure that the CEO of the hospital believes that he can grab the high school gym if he needs a triage center. I'm sure that the superintendent of schools believes that that property belongs to the school system and she controls it. The chief of police probably believes that he can declare a state of emergency and that he can organize a response. And I'm sure our city manager believes that she, in fact, is quarterbacking all of this and has authority over all of the other moving parts. I'm not 100% sure what the right answer is for how all of those pieces should coordinate, but I do believe that we've not done a particularly good job. We don't know how one hospital is supposed to cooperate with another hospital. We don't know what our roles are. We don't know what the expectations are for those roles. We don't even know what the chains of command are, so that we can act consistently with our own job to do and make sure that as a unit we are working efficiently. I'm not saying that we haven't done any of that, but I think that it is extraordinarily ethically incumbent upon us to be very, very clear about public coordination. Now, if those are the broad general topics, they yield a series of specific questions. And I've categorized these questions into three parts. The first part will be broad societal concerns, things that individual hospitals or healthcare organizations really do not have the authority to answer themselves. These are the kinds of things that society really needs to answer on a higher level. The second category is the exact opposite. Kinds of questions that a specific healthcare organization really does need to answer and needs to answer based on its own position, its own personality, if you will, and its own context. And then a third category will be questions that sort of cross between the two. They're at the intersection of how broad social judgments will impact the specific decisions that any particular organization might need to make. I've worked with a number of ethics committees at a number of different hospitals and other healthcare providing organizations to answer many of these questions. My goal today is not to provide you with those answers, but rather to list out the questions. And then later during question and answer, we can zero in on any specific items of greatest concern. So here are the questions. Let's begin first with broad societal questions. 1. Who should be in charge of coordinated response efforts? Federal, state, regional, local authorities, how do they work with one another? 2, under what conditions are mandatory quarantines ethical? 3, under what conditions are mandatory business closures ethical? Of course, we've seen a lot of these things happen already. 4, is it ethical for healthcare facilities forcibly to commandeer private or public business or educational infrastructure and other resources? 5, is it ethical for the pharmaceutical industry to suspend human clinical trials or otherwise adjust protocols in order to rush a vaccine into production? This is an extremely interesting issue, and it is a broad societal level concern. Of course, we all want to work as quickly as we can to find both treatments for and vaccines against the COVID-19 virus. That might mean that we need to take shortcuts or that we need to adjust our protocols in research. Is it ethical to do that? When time is of the essence, is it ethical to take greater risks in how we approve something for general use? And of course, if we do get a vaccine into place, we then need to ask question number 6, would it be ethical to compel vaccination? Does the government have the power to tell everyone that they have no choice but to be vaccinated? I believe we did that during polio. I know that New York State did that, I believe, last year during a measles outbreak. And then the most interesting version of combining these two questions together. Would it be ethical to compel vaccination with a vaccine that was developed under adjusted safety and efficacy testing protocols? That is, if we answer question number 5 by saying, yes, when time is of the essence, let's change our protocols, even if that reduces our confidence in terms of safety and efficacy. Then, of course, the question will be, does an individual have the right to say, look, I would be happy to be vaccinated had you followed all the protocols, but you cannot ask me to take a vaccination that, in my mind, still feels somewhat experimental. Let's shift then to facility-specific questions. I'll run through these as quickly as I can. 1, may staff members refuse to come to work? You just refuse and say, I'm sorry, I'm not interested in taking those risks. 2, do staff members have a right to refuse to provide services to high-risk patients? That is, even if you do come to work, are there certain circumstances where you will have the ability to say, I'm sorry, I won't do that? Of course, the extreme would be you're asked to treat a known COVID positive patient without any PPE. That's an extreme version. Do you have any rights to refuse to provide services in risky ways? 3, do patients have a right to refuse services from high-risk providers? We're very accustomed to the fact that as healthcare providers, we are able to require that patients get tested and that we know what their disease status is so that we know how to respond appropriately to them, including by protecting ourselves. Does a patient have a corollary right? Does a patient get to say, look, right now I'm COVID negative. I don't want you near me until I see your test results. Tell me that you're a safe provider before I let you provide services. Do patients have the right to control their providers? 4, should rotation of dangerous staffing assignments take place to reduce the risk of contagion, or should all staff members take their turn? I mentioned this before. Do we want everybody taking their turn, which spreads the risk out, but of course, in that sense, becomes riskier overall? Or do we want to concentrate the risk, which of course reduces the risk of contagion, but increases the risk that a particular staff member will be exposed? And to keep going with this question, should some staffing assignments be sequestered from contagion so that non-pandemic related treatments can continue during a high-risk period? Are there some providers who do things that are unique and only they can do, and those providers need to be protected especially well, because if we lose them, we lose the ability to do certain things? Are there certain even non-clinical jobs that are so important that those individuals need to be absolutely protected from contagion? Because if they can't get their jobs done, everything comes to a crashing halt. I would think about IT potentially as falling into this category. 5, should staff who have elevated risk factors be excused from hazardous duty? Go back to question 1 for a moment. May staff members refuse to come to work? And I would suggest to you that there are at least 3 possible answers to that question. Answer number 1, no, you have to come to work. Done. End of story. One extreme answer. Opposite extreme answer. No, you don't have to come to work. It's up to you. It's completely voluntary. You don't want to come, you don't have to come. That's the other extreme version. There is a moderate version that says all staff members have to come to work except under very specific circumstances. There will be exemptions or exceptions granted for specific reasons. That's question number 5. If we have a healthcare provider who is at elevated risk, perhaps that individual is immunocompromised either because of a treatment or of an illness, or perhaps they are of advanced age or have other underlying chronic health conditions that put them at great risk. Should they be excused from hazardous duty? One version would be they don't have to come to work at all. Another version would be they should be shifted to a different type of work that is less risky, or provided with an alternate means of doing their work, like telemedicine, that protects them from contagion. And then we can extend that question to number 6. What if the staff member is healthy, but they have a family situation which is dangerous? Now, the extreme version of this is if you have young kids, you don't have to come to work. And that may be far too loose a position to hold. But what if a staff person is the sole caretaker? Necessarily, there's no one else to do it. The sole provider of support to a family member or a loved one who themselves is at an elevated risk. So I'm healthy, but my spouse, who is debilitated and depends on me for care, is immunocompromised. Would I then be able to claim that in order to protect my family, I also should be excused from hazardous duty? 7, may staff members be quarantined while working? Originally, the CDC gave guidance that said that any staff member who was having symptoms should voluntarily self-quarantine for 14 days. I believe we've already moved away from that recommendation, and I can imagine that as staff members become ill at large numbers, we may even have to move further. 82%, as far as the last numbers that I saw, of the individuals who become infected are likely not to have serious symptoms. If a healthcare provider becomes ill and is confirmed to have the virus, but is still functional, should they be required to come to work and potentially work in a quarantined ward? COVID positive providers providing services to COVID positive patients in a segregated unit. Can we ask you to work while ill? Number 8, do any particular staffing assignments exempt an employee from hazardous duty? This is a slightly different version of the question that I asked before, and we've already sort of talked about this. Are there any things that are so unique that we need to protect those staff members from any hazardous duty? 9, how should we compensate those at greater risk? Do we need to give people hazard pay? 10, how should we prioritize recipients of personal protective equipment or vaccines? This will have 2 components, the first being providers of care, the second being recipients of care. I will tell you that at one facility where I am under contract, we got an ethics consult on this, and we wrote an entire policy on rationing of PPE. We made it very clear that the highest priority for PPE are providers who are providing services directly to patients face-to-face and are at risk, therefore, of contagion. That providers should have first priority, because if they get sick, then we lose the capacity to help anyone. We then had a tier 2 and a tier 3, and we went through a whole process for how you would determine who receives PPE, but there definitely needs to be an answer on that. 11, how should we prioritize recipients of other scarce treatments, things like ventilators? Who gets intubated, who does not? And in the extreme case, can we ever take someone off of a vent? Can we ever extubate a patient in order to liberate those resources for someone else with a higher likelihood of survival? 12, when does it become appropriate to restrict visitation? I think we're already there. I know you're already there. I would have argued that as soon as the World Health Organization declared a pandemic, you were there. Certainly when regional cases were identified, you were there. Notice that there's a change in the standard of care here. It's going to be very important for our discussion later. But I think we already recognize that people who previously would have said that they had a right to visit in the hospital, that right has been taken away from them. 13, is it ethical to house suspected COVID-19 positive patients with known positive patients when space is limited? In the early days, it's going to be, hopefully, people will have private rooms, and if not private rooms, we will be able to segregate groups of people according to their COVID-19 status. Known positives in one unit, known negatives in another unit, and then suspected potential positives in a third unit. As we begin to run out of space, what are we going to do with people who have not been confirmed but might have the disease? If we place them with COVID positive patients, they may get infected even though they didn't already have the virus. On the other hand, if we place them with COVID negative patients, they may spread the disease that we do not yet know they have. So how are we going to segregate individuals when space becomes limited? Intersecting questions. This last set of questions comes at the connection between broad social determinations and specific facility actions. 1, should broader social considerations impact local decisions? I have argued in one of the consults I did for another hospital on vent triage, I have argued strenuously that as healthcare providers, we need to retain at least a commitment to the most core ethical, medical ethics commitments that we have historically maintained. This is part of disaster ethics and moral dilemmas. That is, what are you going to give up and what are you not going to give up on? And I argued that we should not give up on the idea that we treat patients without judging them morally or socially. That social considerations should not impact local decisions on how resources are allocated. But depending on where this goes, we may get contrary guidance from other sources. If 2 people present in need of intubation, one is young, one is old, but they are equal in all other regards, should age by itself be a criterion for determining who receives the resource? Is there a preference to saving the young? Now, I think age should matter if it is an indicator of a poor likely clinical outcome. But I don't think that age by itself should matter because somehow young people are worth more than old people. But that is an open ethical question. We could debate that rather strenuously, and honest people could disagree on that point. 2, how should admissions criteria change in the event of a local outbreak of a pandemic based on acuity of need? Notice that the standard of care has already changed in this regard, and this is important for what I'll tell you later. The standard of care has already changed. Elective procedures have already been delayed. Even some things that are not considered elective per se, but are not urgent, are being delayed so that we can generate a surge capacity for what we believe is coming our way. That means we have already changed our admissions criteria by arguing that you must have a higher acuity of need before you can come to the hospital as compared to what would have gotten you into the hospital a month ago. There's an analog to this, which is question number 3. How should discharge criteria change in the event of a local outbreak of a pandemic? That is, should we be pushing people out of the hospital faster than we otherwise might? This is based on the risk of hospitalization itself. Especially during a pandemic, it's true all the time, but especially during a pandemic, a hospital is really not a very safe place to be. I'll give you an example. One of my contracts is with an acute care psychiatric hospital. We have a patient in the hospital, we had a patient in the hospital who was committed under a temporary detention order and a civil commitment order. He has a long history of schizophrenia, and he has very severe paranoid tendencies. He believes that people are out to get him, and therefore he has isolated himself in his apartment. He manages to feed himself and clothe himself, but living a very marginal existence, locked up in his own apartment. He was brought in on a TDO, and he was civilly committed because secondary to his mental illness, he clearly was living, he was placing himself at risk. Came into the hospital. During a pandemic, someone whose paranoid tendencies are so pronounced that he will voluntarily self-isolate in his own apartment, that's exactly the kind of patient who should be in his own apartment and not in a congregate living setting like an acute care hospital. Should we send him home now, even though he never would have met discharge criteria a month ago? As long as we can meet his ADLs, his food, his clothing, I think that person would be much safer without acute psychiatric treatment in his own apartment, self-isolating, than he would be receiving good psychiatric care, but living on a ward with many others. 4, does a healthcare organization have an ethical obligation to share resources with harder hit localities or facilities? One of the hospitals where I'm under contract, I got an ethics consult because they had N95 masks, and they also had the fit testing equipment, the hood and the solution that you aerosolize in order to test the fit of the N95 mask. They got a call from another healthcare provider that said, we have enough N95 masks, but we don't have the fit testing equipment. We need the hood. Can we borrow those? And we need the solution. Can we have some of your solution? Does the first hospital have an ethical obligation to share? Another hospital in your region calls and says, we're out of vents, and you have not yet reached capacity. Should you share your vents with someone else? This also gets back to the public coordination issue. 5, does a patient's non-compliance with recommended precautions result in his or her forfeiture of the right to access scarce medical resources? Remember what I said before about making social judgments about patients? A similar argument exists for voluntary risks to health. As a general rule, we do not penalize patients based on their voluntary risks to health. We don't withhold lung cancer treatment from someone who is a lifelong smoker. We don't withhold HIV treatment for someone who shared needles as an IV drug user. We do not say no to a skier who skied into a tree and ruptured his spleen and now needs surgery. We don't say, well, you didn't have to go skiing, so we're not going to use resources on you. We generally refrain from making those judgments. Will that commitment hold in a pandemic? If you have taken all reasonable precautions, you have self-isolated, you have worn gloves and a mask when you were forced to go to the store, and yet you got sick otherwise, if you show up at a hospital and need to have a ventilator, and at the same time, a college student who, knowing all of the warnings, went down to Fort Lauderdale on spring break and gallivanted on the beach with thousands of others, if you both present at the same time in need of the same resource, is your claim stronger because you took reasonable precautions? Is that student's claim weaker because that student ignored guidance? Normally, we would say no to that question, but we'd have to ask that question again in this context. 6, how should we manage patients with diminished capacity who refuse to be tested for COVID-19 when the process for obtaining a court order for treatment over objections takes time? When we have diminished capacity, we often need to to access the court system or a special justice to get an order for treatment over objections? Can we sidestep that requirement in this emergency? And that leads to question 7. Do patients have a right to refuse to be tested for coronavirus? And if so, how should they be treated? Or has that right now evaporated? Finally, how should organizations make decisions about and provide support to employees who are furloughed during this crisis? Should you have to worry that you're eating up your sick days or your personal days when you get sick with the coronavirus, or should those be sick days that you get without counting? What if you do a job that is not being done now? We've simply closed down certain service areas because we're trying to prepare for a surge of COVID positive patients, and therefore you've been furloughed. Does your organization need to guarantee that you'll continue to be paid and that you will have what you need in order to face your own challenges? Those are pretty important organizational ethics issues. Now, to help answer all these questions, I'd like to offer you 3 analogies. As you know, if you've been in my ethics sessions before, I believe that casuistic reasoning is the most powerful way to think about ethics. That when we're faced with what feels like a new and complex ethical issue, we look for analogs that are similar enough to inform our judgment, but are dissimilar enough that they do not present the very same controversy as what we're trying to solve. So arguing by analogy allows us to access moral intuitions or moral judgments that are relatively settled and apply them to what feel like novel circumstances. I have 3 analogies that can help in that regard. The first one goes back to an ethics consult that I was asked to do about a hospital's policy regarding active shooters. You might remember this slide. Law enforcement no longer tells us that we should shelter in place when there's an active shooter. That strategy doesn't work. The new mantra when you are in an active shooter situation is run, hide, fight. Now, I want to draw your attention to the right-hand upper corner of this slide, because what we have here in the run, hide, fight scenario is a picture of 4 providers, healthcare providers. We can tell that they are healthcare providers. They're in scrubs and white jackets, and they are running away. And it's very clear that they are healthcare providers, and there's something that's completely missing from this slide. What's missing are patients. The question came to the ethics committee. In an active shooter situation, do we have any responsibilities to our patients, or do we just run immediately? Do healthcare providers have any special ethical responsibilities towards the individuals whom they serve? Do healthcare providers have an obligation to put themselves at elevated risk in order to protect the individuals whom they serve? How extensive should a duty to protect clients be? I want you to see the iterative nature of a good casuistic argument. In answering the question about active shooters, we look to things like our own fire response policies. In the hospital, the policy does not say, if there's a fire alarm, run away. What the policy says is, if there's a fire alarm, check your patients. Try to evacuate your patients. Secure your patients before you flee. Now, it might come to the point where you cannot protect your patients, and at that point, we don't expect you to stand by and die, but you do have an obligation first to stabilize and protect your patients before you worry about your own well-being, which means that you do have an ethical obligation to take your patients' needs into account. From thinking about how we respond to fires, we can make the analogy to active shooters. But by thinking about how we respond to active shooters, we can think about how we should respond to pandemics. And the clear answer is we do have an ethical responsibility to protect our patients. But that leads me to analogy number 2. This is an old consult that I had. There was a woman living in her own trailer. She was receiving home health care services. I've probably presented this case to you before. And the nurses who went to bring her her care, who went to provide services to her in her home, fell through the floor of her trailer. Now, they had known that the trailer was dangerously in disrepair. They knew that the floor was weak, and they had offered Ms. D the opportunity to fix the floor. They found someone who would do it for simply the cost of materials, but the client said, nope, I'm not allowing anyone on my property except for care providers. The providers even found another place where the client could move at the same cost in a much safer environment. And the client said, absolutely not, I will not leave. And the home healthcare workers continued to provide services in that environment and eventually fell through the floor and got seriously injured. At that point, nurses said, we're not going back into that environment. It's inappropriate for you to make us. The supervisor said, that's part of the job. You will go back into that trailer. We got an ethics consult. Based on the first analogy I gave you, we argued that even home healthcare workers do have an ethical obligation to place themselves at risk. However, that risk is not unlimited. And if an organization is going to place its providers at risk, then the organization has an ethical obligation to mitigate that risk as much as it can. There is a limit to how much risk the providers need to take. And so that ethics committee argued these nurses have gone above and beyond the call of duty. They have provided an opportunity for alternatives in treatment. Those options have been refused by the patient. Those nurses do not need to go back into that trailer. It leads to these conclusions. Some roles do require reasonable levels of sacrifice. Police officers have to put themselves at risk to fight crime. Firefighters need to put themselves at risk in order to fight fires. Home healthcare providers have to put themselves at risk in order to provide their services. They go into disgusting situations. They can be covered in bed bugs and cockroaches and all sorts of things. The analogy, of course, is healthcare providers do have to make reasonable sacrifices even when fighting in a pandemic. However, there are limits to that responsibility. Police officers do not have to make themselves into human shields. Firefighters do not have to run into buildings that they know for certainty are about to collapse. Healthcare providers, home healthcare providers, do not need to provide healthcare in a crack house when a drug deal is being struck. If we are going to require that healthcare providers do make reasonable sacrifices, then employers must make reasonable mitigating efforts. Police officers are supplied with bulletproof vests. Firefighters are provided with fireproof suits. Healthcare providers need to be provided with appropriate PPE. If your employer tells you to provide healthcare without any PPE at all, that's like running into a burning building. You don't have to do it. If they give you perfect PPE and you're looking at a COVID positive patient, that's like fighting a fire with the right tools. Somewhere in between, switching from an N95 to a surgical mask, switching from a surgical mask to a bandana, the line between those two extremes will be somewhere, and we need to define that carefully. One last analogy. I had an ethics case consult from a community-based provider that provided services to individuals with intellectual disabilities. One person showed up for services. He was 19 years old and receiving services through the school system, still eligible for school-based support, but he didn't want to be in school. And so he wanted to receive services out in the community. Perfect fit, eligible for the service. We had a slot that would meet his needs. Only one slot left, but Mr. Z could definitely benefit from that service. Mr. Z went home that afternoon with his family, and the family was ecstatic that they had found a way for him to get what he wants, which is an alternate supply of services so that he could leave school and he could live in his own apartment. After Mr. Z left, another patient, another client presented with exactly the same needs, exactly the same ability to benefit, exactly the same eligibility. The only difference between them was that the second client was already older and had aged out of school services, had nowhere else to go, could not receive the services in any other place. Should we prefer the person who came first, or should we prefer the person, excuse me, who has nowhere else to go? This forces us to ask questions about how to allocate scarce resources. When we think about allocating resources, there are a number of values we can use: efficiency, effectiveness, equality. None of those are important when we have scarce resources, as is equity. A maximally equitable distribution of goods or services is that which minimizes harm to the non-recipient of resources or services in question, so as to bring about the least harm to the least advantaged recipients. When When we consider equity, we apply the economic principle of maximin, obtaining the best possible worst case outcome. In other words, if we have to make a hard choice, either one person or one group of people are going to get a resource, or another person or another group of people are going to get a resource. When we think about equity, what we don't ask is who would turn out best if they got the resource, or even how can we be most efficient with the resource. What we worry about is how bad off the worst off person will be based on our decision. And we want to engineer an outcome where the person or group, or the outcome itself that develops because of the choice we made is better than the outcome we would have achieved had any alternate choice been made. A fair approach to rationing is one that seeks to maximize benefit to the least advantaged member of the group. Once minimum standards are met for everyone, additional resources should be used to improve the situation of those who are least advantaged. Another way to say this, rationing a public resource is morally justified if and only if, and notice I stress public, no patient has a right to a vent before they come to the hospital. That ventilator is a public resource that we are going to distribute to those in need. So rationing that resource to which no one has a prior claim is ethical if, one, there actually exists a shortage of the resource in question. In other words, don't ration until you have to. Two, there's an identifiable victim of the failure to ration. In other words, if you choose to do nothing, that is as good as making a choice. Inaction in the face of scarcity is the equivalent of action. It just means that it's a first come, first served system, and that is what you have chosen to rely upon. Three, the victim of the adopted rationing scheme is disadvantaged less than the victim of any other rationing scheme, including the lack of rationing altogether. In other words, the losers in the story that we have created are still better off than the losers in any other story. The people who would have died anyway, and the people who receive services who could have survived are the ones who actually get the resource. In an environment of true scarcity, our goal must be to minimize the harms done rather than to maximize the benefits received. And allocating scarce resources, our only constraint on the lower end is to satisfy minimum standards of care. And those standards will change in a disaster circumstance. That is my final point for today, is I want to talk to you about the central ethical concept, which is the fact that the standard of care, which creates for us the minimum that we must do in any particular circumstance, is defined by the context itself. I will explain. You'll recall just a moment ago I said that I'm not big on theory, that I prefer to argue in ethics by a casuistic method, by comparing and contrasting different cases. Well, I want to introduce you to one ethical theory now. Virtue theory. It goes all the way back to Aristotle in ancient Greece. Always act consistently with the standards of the role you play in life. We all play different roles. Some of us are parents, some of us are spouses, some of us are doctors, some of us are nurses, some of us are administrators, some of us are ethicists. We all play different roles. We have different relationships. We have made different promises based on those relationships. According to Aristotle, if you understand the role you're playing, you will be able to discern what people can reasonably expect from you based on that role. You have an ethical obligation to satisfy that reasonable expectation. The word for this is arete. Arete is a Greek word, a classical Greek word, and it is often poorly translated as virtue. It is not a list of good things you're supposed to do. It is the following way that we might use the word virtue. You are a doctor by virtue of the fact that you, fill in the blank. You are a social worker by virtue of the fact that you, fill in the blank. In other words, what is the essential character of being the kind of thing you are? What is the characteristic function or activity? What's the essence of being what you are? Once you know what the essence is, you'll know how you should behave. Doctors are required to do certain things because they are doctors and because the specific excellence of doctoring requires of them. If they want to call themselves doctors, they need to act consistently with those expectations. those expectations change depending on context. There will be altered standards of care in a disaster. Just as there are different standards of care depending on where you are in providing healthcare, the rural walk-in clinic versus the tier 1 trauma center, just because there are different standards of care of when you provide healthcare. So as new medicines develop, as new techniques develop, you generate an obligation to provide them, an obligation that did not exist prior to their development. So too, when a disaster hits, the standard of care itself will change. The fundamental ethical obligation of a healthcare organization in the face of a pandemic is to clearly develop policies that are succinct and clear and can communicate to staff what we expect of staff in the pandemic environment. You've already done this by telling people that they can no longer visit. You've admitted that the standard of care has changed. By telling people that they need to wait for their cataract surgery, you have told them that the standard of care has changed. Those are the easy ones. There will be more difficult ones. Documentation will have to change. In the heat of battle, you will not have time to satisfy our current expectations for documentation. Same thing with confidentiality. HIPAA standards will be relaxed so that we can use different modes of communication, so that people can visit with one another in a way that never previously would have been considered confidential or private. We will reduce the number of patient contacts, which means that we will provide healthcare in new ways by telemedicine, by moving telemetry machines outside of the patient's room. We will do things that alter patient contact. Oversight might change. Right now, if a nurse practitioner or a physician assistant needs to report certain things to doctors, we may change those requirements so that we can amplify the effect of those physician extenders in a hospital. And of course, we're going to have to make decisions about distribution of resources. We're going to have to say no to people we would never have said no to before, and we may even have to withdraw services from people that we would have continued to support in the past. It is absolutely essential from an ethical perspective that every healthcare organization think about these issues, determine what a new standard of care is going to look like, write a policy that explains that, and communicate that policy clearly to staff so that staff know what they should do. Hospitals also need to coordinate with state level and federal level organizations so that they know that they can protect staff members who invoke an altered standard of care, so that we can then face what feels like a moral dilemma as armed as possible to deal with the difficult decisions at hand.